Fibrinogen is called factor 1, and it's essential for the final step of clot formation where it's converted to fibrin. Measuring fibrinogen levels helps diagnose bleeding disorders and monitor conditions like DIC or fibrinolysis. Since fibrinogen is an acute phase reactant, its levels rise in inflammation and injury. Low levels, on the other hand, predispose to bleeding. Its normal levels in adults are 200 to 400 milligrams per deciliter or 2 to 4 grams per deciliter. Newborns have lower levels, and in the elderly, fibrinogen levels tend to increase with age. Critically low levels below 100 are associated with spontaneous bleeds, and several factors can interfere with measurement. Blood transfusions could dilute or alter results. Diets rich in omega-3s or 6s can reduce fibrinogen levels. Certain meds also influence results like estrogen and oral contraceptives, which tend to increase fibrinogen, while anabolic steroids, androgens, and others can decrease it. This means lifestyle factors and therapies must be considered when interpreting these levels. It's using the same blue cap top and it requires no fasting. And when we interpret these fibrinogen levels, it requires looking at high and low values. Elevated fibrinogen can be seen in acute inflammatory reactions like RA, glomerulonephritis, pneumonia. It also rises after trauma, during pregnancy, and with smoking. High fibrinogen is a risk factor for cardiovascular disease, including stroke and peripheral vascular disease. On the other hand, decreased fibrinogen occurs in the liver or liver disease, DIC, congenital conditions, advanced cancer, malnutrition, or even after a massive transfusion. And critically low fibrinogen levels indicates a risk of uncontrolled bleeding. So to summarize, it plays a crucial role in clot formation and is an important acute phase reactant. Another specific test that we can consider is thrombosis indicators. And thrombosis indicators are specialized tests that measure breakdown products of clotting activity. These include fibrin monomers, fibrin split products, fibrinopeptide A, and prothrombin fragments. Normal ranges are really, really low, and elevated results can reflect an increased clot formation and breakdown, which helps us identify conditions like DIC and hypercoagulable states. We order thrombosis indicator tests to document that fibrin clot formation is actively occurring in the body. These tests support the diagnosis of DIC, and they can also be used to follow treatment in hypercoagulable states. Essentially, they help us determine whether clotting is in overdrive and whether the body is simultaneously breaking down fibrin at an accelerated pace. Thrombosis indicators do have some external factors they can be influenced by. Rheumatoid factor, surgery, or trauma can falsely elevate results. A traumatic venipuncture may raise fibrinopeptide A levels, and menstruation can increase fibrin degradation products. Medications can also play roles like barbiturates, heparin, etc., while warfarin and other oral or anticoagulants can lower them, which highlights the importance of interpreting values in the full clinical context. There is a lab specific tube. It could be a blue top citrate tube, but there may be lab specific tubes that are required, and there does not need to be fasting. When we see an increase in thrombosis indicators, it suggests conditions where clotting and breakdown are occurring simultaneously. This could be DIC, thromboembolism, advanced malignancies, inflammation, trauma, or even post-op states. And elevated results could also be seen with deficiencies in natural anticoagulants like proteins C or S, or even antithrombin 3. Because results can also rise after surgery and trauma, we must interpret them cautiously and always in the light of patient history and presentation. When evaluating unexplained bleeding, we start with a complete blood count and smear to check platelet count and morphology. Then we add coagulation tests like PT for the extrinsic pathway and APTT for the intrinsic, and thrombin time for fibrinogen assessment. Factor assays can identify specific deficiencies, while mixing studies can detect inhibitors. Platelet function testing, von Willebrand factor assays, and bleeding time or platelet function analyzers can uncover qualitative platelet disorders. This systemic approach helps us move from broad screening to precise diagnoses.